Good evening, everyone, and welcome to tonight's webinar discussing pediatric tumors. This will be the last webinar in the series before we take our break for the summer and potentially restart some in the fall, depending on what's going on with the virus situation. We just concluded the hand webinar series. Tonight's webinar was tendinopathies. If you missed that, you can certainly go to the website to view that recording as well. So tonight we have an outstanding internationally renowned faculty to discuss the various topics. We're going to start off with Marty Herman from Drexel University, St. Christopher's Hospital for Children, that will discuss the principles of tumor workup and tumors in general, as well as a couple of the benign bony lesions. We'll then move to Julie Samora, who will discuss the remainder of the pediatric benign bone tumors. Subsequently, we will move to Christine Ho, who will discuss the soft tissue tumors that are benign in nature. And then Carrie Henselman will discuss the systemic conditions that we can see that lead to tumors. And finally, Alex Arcata from CHOP will discuss malignant tumors of the bone. So thank you again to all of our faculty. And with that, I'm going to turn things over to Marty.
Josh, can you hear me?
Yep, you're good. See you and hear you.
Hello, everyone. Good evening. Welcome. I am going to do this talk actually with Julie. So we're going to have two parts to the benign bone tumors talk. We will, before I even go forward, Alex Arcata gets big props. The majority of the imaging in this lecture are from this talk he gave at the AOS. So thank you, Alex. So here's our outline. I thought it would be important for us to think about an approach to tumors because while very few of us are actually tumor surgeons, many of us, all of us actually, are forced at some point to identify tumors and manage them. And in particular, as a pediatric orthopedic surgeon, bone tumors turn out to be a very common diagnosis that we operate on. So we'll talk about the clinical evaluation, some radiographic understandings of the tumors, and then I'll give a couple basic concepts about decision-making for benign tumors, and then Julie's going to do the majority of our, as I'll call it, the laundry list of benign bone tumors, all of which are relatively common in a pediatric orthopedic practice. So let's talk about the clinical evaluation first. So just like everything else in medicine, the chief complaint regarding potential bone tumor is important. Often with benign tumors, it's a mass, but occasionally it is just generic sense of pain. And it's not that uncommon. We'll see, especially in the malignancies, that the chief complaint initially isn't necessarily just a lower extremity or an arm complaint. It's related to something such as the fever, weight loss, lack of energy, systemic or other signs and symptoms that initially may not even seem like they're related, but indeed are indicative of a tumor. The history then focuses specifically on the duration of the symptoms, the types of the symptoms, all the typical questions that we ask. And in the benign, especially how they change over time, because a lot of them we just observe. And really some of the decision-making comes when we have to make a change because of size difference or pain changes. And then family history, past history, all those things will factor in, as you'll see, specifically when we talk about some of the genetic related tumors. So this is Dr. McEwen, and I don't know if any of you remember him, but he is one of the founding fathers of pediatric orthopedic surgery, and he was one of my partners when I first started practice in 1996. And he had this statement that I still believe, I think every pediatric orthopedist has to keep in mind. It says every busy surgeon should see one malignant tumor a year, and if you don't, probably missed it. Now, if you knew what Dr. McEwen's wit was like, you'd understand a little bit what he was saying, but what he was saying is, pay attention to details when you're taking care of patients. And when you think about potential red flags, especially in dealing with tumors, size that doesn't make sense, pain, especially at night, and these systemic symptoms I talked about need to be factored in when you're dealing specifically with these tumors. Physical exam talks about general appearance, and again, every now and then you do have a child whose chief complaint is related to energy or lack of ability to walk or something, then they are uncomfortable because of their disease. If it's a lower extremity, we might tend to look at them walking. If it's upper extremity, we'll look at active mobility, and in both cases, you're going to look for several different things. So through the extremity exam, you're going to look at the skin and the muscle mass. You're going to palpate lymph nodes proximal to where the lesion might be. And then you're going to look for things that you might not have considered as part of the tumor evaluation. But some of these tumors, for example, which is osteochondromatosis, changes the shape of the limb. That also can occur in the lower extremity as well. So paying attention to generalized pediatric orthopedic findings is important. And then finally, evaluating the mass. So the mass includes the size, the tenderness, the mobility, all those details that may or may not direct you into a very aggressive workup or to observe these kids. So I am going to thank Alex, because this is his approach, and we'll talk through this, but radiographic evaluation really is probably one of the most important things that we do when we're evaluating tumors. So we start with a stepwise approach that has 4 components, talking about tumor location, tumor's effect on the bone, then the bone's reaction to the tumor, and finally associated findings. Let's talk about tumor location. There's 3 different components, eccentric versus central. We talk about the bone specifically because it turns out the bone that is in will sometimes guide us to the diagnosis. And finally, where specifically in the bone that is it epiphyseal, metaphyseal, diaphyseal? That will help us make our diagnosis. So eccentric classic lesions include the non-ossifying fibroma, such as this one. And eccentric meaning that it's toward the edges of the bone, as opposed to this centrally placed tumor, which here is a big unicameral bone cyst. But LF and osteoid osteoma, classically eccentric. Central tumors include the bone cysts and fibrous dysplasia. Then we get into what bone. So diaphyseal pediatric tumors that fall into this diaphyseal category include what the mnemonic is FA-HEL, fibrous dysplasia, adamantinoma, histiocytosis, Ewing sarcoma, leukemias, lymphomas are all diaphyseal lesions. So whenever you're looking first glance at a lesion in bone and it's diaphyseal, think of these particular diagnoses. Now remember, there are some that don't always follow the rules. Osteomyelitis in particular, one of those, and the osteoid osteoma being the other. Spine is another one. So if it's in the posterior elements or in the body of the spine, it changes your differential diagnosis. The posterior elements most commonly are involved with osteoid osteomas, osteoblastomas, and aneurysmal bone cysts. In the vertebral body, osteomyelitis, Langerhans cell lymphoma, leukemia, and metastatic diseases are all things that we typically will see. And as a person who takes care of pediatric spine, it is very useful to remember these rules, because fortunately most of what we see in the spine is benign, but it is important to remember aggressive to go do biopsies and work up these children. So where in the bone is the lesion? So once it's in the epiphysis, about 3 different diagnoses that are kind of classic, and this is an example on the left of a chondroblastoma. So in the epiphyseal areas of the child, chondroblastoma, Brody's abscesses, and giant cell tumors, mostly in older, closer to end of growth, we see. Occasionally, you'll see bone cysts that erode into or across the growth plate, and clear cell chondrosarcomas in the group. But whenever you're on a test, epiphyseal tumors are probably one of these 3 in a standard testing situation. Now, the metaphysis is a very common place for tumors, and it doesn't actually help us as much as you think, because many tumors do indeed start in or become part of the metaphysis. This includes the non-ossifying fibroma, aneurysmal and unicameral cysts, the osteoid osteomas, and the osteochondromas in particular, and then even malignancies all tend to linger first in the metaphyseal bone, mostly because it's turning over so fast. So it's especially in these malignancies where there's a lot of cell turnover, it's a common place for them to begin. What's the tumor doing to the bone? So this is part 2. So this is where we talk about the margin. In the language is such things as well-defined or geographic, well-demarcated. We talk about the type of lesion being lucent or lytic, and whether the matrix is something that we can identify. Is it osteoid, chondroid? Is it mixed? Or is it collagenous in some way? So there are some examples of 2 very common problems that we might see. This is a non-ossifying fibroma with a very geographic, well-defined lytic area and little septae. As you can see here, this is a more destructive lesion. This is a Ewing sarcoma. and it has an ill-defined the borders. It has a lytic, destructive appearance to it, and no matrix. What is the bone doing now to respond to this tumor? So cortical changes are very helpful for us. So in this case of an osteoma, the cortex hypertrophies. In the case of tumors, malignancies, we see very aggressive mineralization and periosteal changes. This is I think this is an osteosarcoma with a sunburst, which is this sort of articulated appearance to it. And this Codman's triangle is this very sort of what appears to be a well-defined periosteal reaction, but what it is constant bone turnover responding to this tumor. So bone reaction to the tumor is another indication of what the tumor might be. And then finally, associated findings that go along with this. So pathologic fractures certainly are helpful for us and can signal both benign and malignant tumors. MRI findings of a soft tissue mass are very much consistent with malignancies. So MRI becomes a very important part of the workup, especially when malignancy is in the different. Significant interval progression and multiple areas of lesions are all pieces of information that help us guide our differential diagnosis and eventually our treatments. So keep these all in mind. You'll hear more about the multiple lesion diseases in a little bit. So tumor decision-making, is it benign or malignant? So benign are well-defined with continuous osteoreaction and reasonable bone remodeling. They tend to be solitary and they almost never have an associated soft tissue mass. Malignant tumors are permeative, destructive with cortical breakthrough, and it's a very good help for us. They have disorganized periosteoreaction. They often have multiple lesions, although they do not have to have them. And the soft tissue mass is often associated with their cortical destruction. So do you operate on these? So benign tumor surgery decision-making really becomes when do you go after them? So in a typical clinical practice, most benign tumors fall into several different categories. One, two, they've caused a deformity in the limb, or three, they have neurological or mechanical signs and symptoms. Other reasons to operate on them, certainly in a pre-fracture situation, would be if you're worried about an impending fracture. That is something such as this, which is a very high risk for a difficult fracture to manage. This is a unicameral bone cyst that is in the neck. So you might choose to operate on this even if it's an incidental finding because of the risk for impending fracture. And then finally, there are times when we just don't have a diagnosis and you're not sure, is this something that's more serious or is it something that is indeed benign? We will often do incisional or excisional biopsy just to make sure that we know what diagnosis we're dealing with. So getting into our benign tumor laundry list, Julie's going to do the majority of these, but I will cover the two top ones here. So an isolated osteochondroma is the most common bone tumor that is seen in children. It's about 40% of all of our tumor diagnoses, and the ages of presentation range of fairly wide, actually, from about 10 to about 35 years of age on average. But younger children, especially those with MHE, will present at early times. They often present with a bump or a mass, and it's most commonly seen around the knee or the shoulder. We see this concept of malignant degeneration in a very small percentage of them. That percentage goes significantly higher when you're dealing with someone who has multiple hereditary exostosis or MHE. I typically say for osteochondromas, you excise for pain, mechanical symptoms, or nerve compression most commonly. And that most of these are very simply excised with a metaphyseal muscle split, and then excision of the cartilage cap, as well as as much of the bone mass as you need to make the bump go away. And with the majority of the time, you are able to have this go away forever. Chondroblastoma is the one that appears in the epiphysis. This is a benign but aggressive lesion with almost 1% of them having a risk for lung metastases even. This makes up a relatively small percent of benign bone tumors. The age range is, again, fairly wide. Clinical features with this are generic, which is sometimes a problem. They come with pain and swelling. Often they will present just with loss of range of motion and pain. There will not be a sign that says I have chondroblastoma. X-rays are obviously very helpful, but it seems that the best imaging for this is MRI because it really gives you a sense of where it is in the epiphysis, where it is relative to the cartilage of the joint that it's adjacent to, and how aggressive it actually become. On a test question, they are round and ovoid cells that are giant cells with chondroid matrix and the so-called chicken wire approach or appearance to it. Surgically, they are treated by a transepiphyseal resection, trying to avoid the articular and growth cartilage if possible. Graft, in a rare case, even cementing are useful, but the majority of these are treatable, but 10% recurrence is actually a fairly high number if you think about it for a benign tumor. So this is one of those tumors where you really have to lay the crepe for the families. Josh, I'm going to stop there because I want us to transition smoothly over to Julie's part.
Great.
Julie,
Thank
you ready
you very
there?
much, Marty, for that introduction. Julie, take it away.
Great. Can you see my screen and hear me okay?
Yep, perfect.
Okay, great. Thanks, Marty. So I have no disclosures relevant to this talk. I'm going to talk specifically about osteoid osteomas, non-ossifying fibromas, fibrous dysplasia, and UBC ABCs. So I'll first start off with osteoid osteomas, which are small, discrete, and painful lesions. The typical presentation is pain at night with alleviation by NSAID treatment. Can cause painful scoliosis in adolescents, and males are 3 times more commonly seen than females. The vast majority of lesions are in children, but the range is about 5 to 30. You can see the location here with the lower extremity being the most common area. The pathophysiology includes a nidus, which is a central nodule of woven bone and osteoid with osteoblastic rimming. And then there is a reactive zone, which is an area of thickened bone and fibrovascular tissue. The theory behind the pain is that there is an increased local concentration of prostaglandin E2 as well as COX-1-2 expression, which is why they respond so well to NSAIDs. There is also an increased number and size of unmyelinated nerve fibers within the nidus. Here's your typical histology where you can see a clear demarcation between the nidus as well as the surrounding bone. And you can see this uniform osteoid seam of immature osteoid trabecula with some sharp borders of osteoblastic rimming. So that's a pretty standard slide. The treatment by far and away, most of the time, is simple conservative management and NSAIDs. You can also use percutaneous radiofrequency ablation, but not around the growth plates and not around the spinal cord. And RFA does have up to a 15% recurrence rate. If patients fail conservative management, certainly surgical resection with curative works very well. The prognosis, most of the pain actually burns out within an average of 3 years. And the lesion can actually spontaneously resolve, but it can take as long as 7 years. In the spine, if you resect this lesion, you can actually have complete resolution of the scoliosis, which is kind of interesting. I do want to take one moment to distinguish between the osteoid osteoma, sorry, I misspelled that, and the osteoblastoma. On the left, the osteoid osteomas are typically 1.5 centimeters or less, and the osteoblastomas are always greater than 2 centimeters. The former is most often seen in long bones, whereas the osteoblastoma is often seen in the posterior elements of the spine. The osteoid osteoma is self-limited, where the osteoblastoma is progressive. There is no growth potential for the former and aggressive growth potential for the latter. And osteoid osteoma almost universally responds to NSAIDs, whereas the osteoblastoma does not respond to NSAIDs. And your first line of treatment for the osteoid osteoma is non-surgical, whereas your first line of treatment is typically surgical for the osteoblastoma. But on histology, they look pretty much the same. So moving on to non-ossifying fibroma, some of this was alluded to by Mark, but it is a benign fibrogenic lesion related to dysfunctional ossification. And this is one of the most common benign bone tumors that you will see in kids. Males, again, more often affected than females, and most often this is seen in the metaphysis of long bones. The far and away most common area that you'll see this is in the lower extremity. Typically, patients present because of some other issue, and this is an incidental finding on X-ray. Patients can present with a pathologic fracture. What you'll see on X-ray is this metaphyseal eccentric bubbly / lytic lesion. You can see has this nice sclerotic rim around it. As the patients mature, the lesion does move into the diastasis and does become more sclerotic. The histology is pretty bland. So you'll see these fibroblastic cells in whorled or story-form pattern, but again, not super easy pattern to recognize because it is very bland. The treatment for these is really observation. You'll see them again at 6 months, get a repeat x-ray. You'll see them at 12 months, get a repeat x-ray, and then typically yearly x-rays until it resolves. If they happen to have a pathologic fracture, you'll treat that as necessary, typically with casting. And then for those symptomatic enlarged lesions and those that are at increased risk for fracture, curettage and grafting works quite well. Moving on to fibrodysplasia. This is a developmental abnormality with failure to produce normal lamellar bone. In this case, females are more often affected than males. And again, most patients are in their younger years. The proximal femur is the most common location. I have this GNAS mutation in yellow because this is something you will see on your boards, whether it's your in-training exam or your actual board examination. And that the GS alpha protein activating mutation does affect the cyclic AMP signaling pathway. And this is something that will be a test question for you. There are 3 associated conditions, including McCune-Albright syndrome, which is the figure where you can see patients with cafe au lait spots and coast of Maine patterns. You can also appreciate endocrine abnormalities such as precocious puberty or renal phosphate wasting, and they can have unilateral polyostotic fibrous dysplasia. Another associated condition, and again, all of these can be on your exam, is Mazabrod syndrome, where you can have polyotic fibrous dysplasia associated with soft tissue intramuscular myxomas that you can see on the bottom here. Then finally, fairly rare, but not rare on your tests, is osteofibrous dysplasia, which does affect the tibial cortex. The prognosis is generally good, but this is one of the benign bone conditions that can go to malignant transformation. It can lead to osteosarcoma, fibrosarcoma, or malignant fibrous histiocytoma, and this is why you want to follow these. Patients can present in an asymptomatic fashion, typically seen again as an incidentaloma, but they can potentially have pain if they have a stress fracture. Their lesions can be monostotic or polyostotic, and often they do have these cafe au lait spots. We talked already a little bit about the radiographs, but they can be highly lytic lesions. They can have a ground glass appearance. You can have some punched out lesions, and certainly the Shepherd's crook deformity is very pathognomonic. The histology is pretty unique. This is fibroblast proliferation surrounding islands of woven bone. You might have heard the term alphabet soup. Before we had to worry so much about being politically correct, you might have seen in textbooks Chinese letters, so you can kind of make out these little letters there. So pretty unique, distinguishable pathology for you on your exam. The treatment is generally observation to the asymptomatic patients. If patients are symptomatic or they have polyostotic fibrous dysplasia, you can consider bisphosphonate therapy. For those patients that have truly symptomatic lesions, they have neurologic compromise of the spine, they have coxa-vara, then you need to be more invasive and take a surgical approach. It's important when you're grafting these lesions not to use autograft, but to use allograft. Moving on to the last 2 is cameral bone cyst and aneurysmal bone cyst. I'll first start with the UBC. This is a serous fluid-filled metaphyseal lesion near the physis. This is really a pediatric condition. The proximal humerus is by far and away the most common location. As the patients get more skeletally mature, the lesion does progress toward the diaphysis, can get smaller, and can fully heal. We consider those active lesions the ones that are close to the physis, and the latent lesions when there is a space of normal bone which separates the cyst from the growth plate. Patients can present as an incidental finding because they got an x-ray for something else, or they can actually present with a pathologic fracture. You can see on the top right here, this is sort of the pathognomonic x-ray finding with this fallen leaf sign. You'll see that on your boards. One of the ways to distinguish a UBC from an ABC is the UBC generally does not widen wider than the physis, where the ABC does. If you happen to get an MRI, you can see a dark signal on T1 and a bright on T2. This histology is a cyst with thin fibrous lining containing fibrous tissue, giant cells, and hemosiderin. That's going to be what you're going to see. The treatment is dependent on, again, the presentation. If they happen to have a pathologic fracture, you can treat them in a sling. If you have this availability at your institution, you can do aspiration or injection with either steroid or bone marrow. And finally, if you have these symptomatic lesions that are unresponsive to your conservative management, or these latent cysts in the proximal femur that are a true structural concern, then you can be more invasive with your surgical approach. And finally, the last one I'm going to talk about is aneurysmal bone cysts. And these are also benign, reactive bone lesions filled with multiple blood-filled cavities. If you look at this figure, right, you can see how that lesion is wider than the distal radius growth plate. And so that's sort of how you can distinguish an AB from a UBC just on radiographs. This lesion can be locally destructive, and it actually can extend into the soft tissue. The vast majority of patients are in their younger years, and you typically see this lesion in the metaphysis. By far and away, the femur and the tibia are the most common locations, but can be seen elsewhere as listed here. This is a busy slide, but I'll direct your attention simply to the highlighted blue translocation, which is 1617. And this is something you can, again, be asked on your either in-training exam or your part 1. There can be other tumors associated with this that are listed below here. Patients can present with pain and swelling about the lesion. They can present also with a pathologic fracture. If you have a spine lesion, it can lead to neurologic deficits. From an imaging standpoint, you will see, as I said before, an expansile eccentric lytic lesion within the metaphysis. You can have a thin rim of periosteal new bone that surrounds the lesion. The MRI findings are very typical. So this is what you'll see on your exam, where you can see these multiple fluid lines and the lesion expanding into the soft tissue. The histology, you really want to look at these lakes of blood. And so what that is these blood-filled spaces without an endothelial lining. And this is a pretty typical histological presentation that should be easily identifiable. Again, non-operative fracture management is your first course of treatment. If there are symptomatic lesions without an acute fracture, you can consider aggressive curettage plus or minus an adjuvant with bone grafting. And the adjuvants I have listed here include phenol, argon beam, and liquid nitrogen. There is a relatively high local recurrence rate, up to 25%, and the younger you are, the higher the recurrence rate is. So that's really osteomas, non-ossifying fibromas, fibrous dysplasia, and your bone cysts. They are benign. They can often be treated conservatively, and you would reserve the more aggressive treatment for those tumors that are refractory to conservative management, impending fractures, or deformity. So thanks for the opportunity to discuss tonight.
Great. Thank you very much, Julie. So we'll move on and change gears a little bit, and we'll start talking about some soft tissue tumors, at least the benign ones, and this will be Christine Ho.
Here we go. Unmute. All right. Can you hear?
Yes.
Okay, great. So we're going to talk about pediatric benign soft tissue tumors. The thing is that these do not appear quite as frequently as the bone tumors do on the OIT and on the boards, but you see these a little bit more frequently in real life. So no disclosures. So we're going to try to just go over, there's a gazillion benign soft tissue lesions, but we're going to try to go over just what's high yield for both life as well as the test. Lipomas, ganglion cysts, giant cell tumor of tendons, epidermal inclusion cysts, hemangioma, AVMs, digital fibromas, desmoid tumors, and then some nerve sheath tumors. So lipomas are the most common soft tissue tumor in adults, but they do appear in kids. And as you know, it's really benign. It's made of fat. It's subcutaneous and kind of rolls around, but mostly stays kind of where it is. The ones that are submuscular actually are less mobile, so they can be mistaken for something else. And so certainly for those who want to get an MRI. The good thing is that they're painless, they're soft, they're rubbery, and again, common more so in adults than in kids, but do occasionally show up in children. They do not change in size or in nature. So you always have to ask the family, is this taking off? Is this with the kid? Is it growing disproportionately more than the kid? Is it waking him up at night? Is it causing pain? Those kind of things. So the diagnosis is typically made with exam alone. If it's totally 100% falls right in line with, it looks like a zebra, it sounds like a zebra, it is a zebra, you don't necessarily need to get an MRI. But if there's anything at all that is unusual, you really should. And I can tell you that from personal experience, because one of our co-residents that was a lipoma, and it started causing pain. And then when they got the MRI and the biopsy, it turned out it was metastatic melanoma, stage 4. And so if it at all is different and things are changing, yes, you definitely need to get a workup. So biopsy if the MRI is not definitive, and treatment, observation alone, as long as you know it's a lipoma and then there's no symptoms. And if it's symptomatic, or if the patient doesn't like it because, you know, of the way it looks, cosmesis, then you can certainly excise it. And so the good news is there's zero chance, unless it's not a lipoma, of it under malignant transformation. And once you take it out, it doesn't come back, unlike a lot of these annoying benign tumors that are not aggressive, but as far as, you know, malignant, but they keep coming back over and over. Like this one, ganglions, which are not malignant, but they come back over and over again. So the most common location is the wrist, dorsal more so than volar. And what that is we think there's some sort of underlying irritation from either a tendon sheath or the joint sheath, and there's a little area of weakness, and that kind of area just kind of balloons out like a little balloon that's full of joint fluid. And the age, the most typical age is 15 to 40, but we've certainly, for those of us that do pediatric hand and upper extremity, have seen them in much, much younger. Women more so than men. And sometimes there's a history of trauma. Sometimes, a lot of times they wake up and they just say, it's there. A lot of times the typical story is it gets bigger, smaller, it disappears, it comes back. So it just kind of keeps changing all the time. And it may or may not be painful. And, you know, I really can't figure out who has pain and who doesn't have pain. It seems the occult ones seem to have more pain. I wonder if it's because it's closer to the PIN and it kind of irritates, but I mean, who really knows? And so on the exam, it should be firm, it should be poorly immobile. And the big thing is you have to turn off the light in the room and get the little otoscope, which is the only thing I've ever used the otoscope for since I left med school, and make sure that thing lights up. So as long as you're 100% right in line, looks like a zebra, smells like a zebra, it is a zebra, sounds like a zebra, the history and physical is diagnostic. If everything lines up, I don't need more you know, studies to tell me that it's a ganglion. However, if anything at all is atypical, it's in a weird location, it's a weird color, the family says it changes color, it doesn't illuminate when I turn off the light, those are times when I get further imaging, and whether that's an ultrasound or an MRI depends on what I think it is and where it is, and other things on the physical examination as well as a history. So if it's truly ganglion, what's the treatment? Well, you can just watch it, because a lot of them just go away on their own. You can splint for comfort, although that doesn't help with the resolution. And in the past, we would talk about aspirating them, but we've actually found in a study that Dr. Ack and I are co-authors on for post-QSPI that there was actually increased recurrence when you aspirated compared to observation. And then the surgery actually has the lowest rates of recurrence, but it is surgery. And whether you do open or arthroscopic is really, you know, up to the dealer's choice. But no matter what you do to it, there's nothing like a good ganglion to make a peds upper extremity surgeon look bad, because no matter what you do, it wants to come back. And so the results for kids versus surgery, kind of difficult to say, because a lot of studies are all over the place, but by far and away, surgery has the lowest recurrence rate, followed by observation and then aspiration. So some variants on ganglion cysts. These are retinacular cysts. So they're like little BB pellets along the tendon sheath, most commonly right at the A1 pulley. Sometimes they're further along on the flexor sheath. And so it does not move with flexion and extension of the finger, and it literally just feels like a tiny little BB underneath the skin. However, these can be very symptomatic on that palmar aspect. With gripping objects. So you can imagine if you've got one in the palm and you're trying to pick up your purse or your backpack or a handle, it's very painful. And so even though there's a risk of them popping or disappearing, there's a good chance that they will pop or disappear their own, a lot of times the kids do want these out because they're very symptomatic. The recurrence rate for surgery is much less than that wrist ganglion cyst, but you just have to let the family know that there is always still a risk of it coming back. Mucoid cysts, and again, this is not really so much in kids, but in adults, and just because this is kind of a high yield topic for showing up on various tests, and that's a small cyst at the DIP joint that's associated with arthritis. You can get an x-ray, sometimes there's a little osteophyte in that area, typically women, typically middle age to older age, and the treatment is vision. And sometimes if you have to take a big wedge of it, you may actually need a skin graft. So Baker cyst, this is very common, as I'm sure you guys know. It's a posterior knee cyst occurring between the semimembranosus and the medial gastroc is the typical location. Insidious onset, it's painless, it's asymptomatic, but the family really doesn't like the way it looks, and it's kind of this, kind of this lump in the back of the knee. So just ganglion cysts, they transilluminate. If it's very typical with the history and the physical, no further studies are needed to diagnose this. And for the vast majority of these, just like ganglions, the treatment is observation. You can try to aspirate it via ultrasound guidance. And again, if the kids have pain or it keeps coming back and they really want it out, you can take it out. But nobody really likes to take these cysts out because there's nothing like taking out a cyst to make you look bad. Giant cell tumor of tendon sheath. It's the second most common soft tissue lesion in the hand. And it's a very firm, non-tender, fixed mass, usually near the radial 3 digits, especially near the DIP joint. And sometimes if they get big enough, they can actually involve the joint with some images on the x-ray from some pressure erosion. And the treatment is just excision of the nodule, and you really have to do a full excision to prevent recurrence, which has been said to be up to 50%. On the pathology, it looks like PVNS, pigmented villonodular synovitis. So it may have giant, despite the fact it's called giant cell tumor, it may have giant cells and it may not have giant cells. So that's kind of misleading. But the thing that they say is they have these histiocytoid mononuclear cells. Do not ask me to point these out. Alex probably could, but that's what it says, histiocytoid mononuclear cells. And I think if you look at this picture, you can kind of see these cells look like monocytes, so the color of monocytes from what I remember. And sometimes you might see these giant cells and sometimes you won't. I think it'd be awfully mean on a test if they put this in there and didn't show you giant cells. So epidermal inclusion cysts, they come by a variety of names. Luckily, most of the time, unless they're really deep, we don't see them. They do present a lot of times to the dermatologist, also known as epidermal cysts, keratinaceous cysts, sebaceous cysts. And what happens is there's some sort of history of trauma, and some of the epithelial cells actually get stuck underneath the dermis. And you get this kind of slow growing papule with this little punctate area in the middle. And if it gets really big, you can see on this x-ray how it can actually erode the underlying bone. And surgical excision is recommended because it continues to get bigger and it may actually get infected. Hemangiomas are a benign collection of bone, of blood vessels. So this just arteries or veins, and it's very common in infants. That's how come they come to see us as pediatric orthopedists. And they can be a reddish or bluish color, and they're usually painless. So when these babies come to see us, we typically just watch them because a lot of times they involute on their own. They get bigger for a little while and then they shrink. And it may actually take years to disappear. If it's in a very, very noticeable place like the face or the head, you can do laser treatment, and some places do offer that. Diagnosis, you can't get x-ray, you might see phlebolus, you might not. And if you're worried about it being like a very high flow lesion, like you feel a bruit or it's very, very aggressive and it's spreading in an alarming manner, then MRI angio can show you what it is. So what's the treatment of these hemangiomas? Again, if it's unclear what the diagnosis is, biopsy, and again, observation for the majority of cases. For the ones who are present past that infantile stage, you can do steroids or NSAIDs, which will slow the growth of the mass, and other non-operative treatments would include compression stockings and wrapping with an A-strap to try to decrease the swelling. If the above fails, you can turn to your interventional radiology friends and ask them to do sclerotherapy or embolize it. And if the lesions are totally resistant to any of those above treatments, those typically I refer them to someone who does vascular malformations for surgery because these do have high local recurrence. AVMs, so you have an abnormal network of arteries and veins. So you can see from this nice picture from the Mayo Clinic, these you can kind of see distal how these are nice and thin with these capillaries, and then For an AVN, you have these really big tortuous abnormal connections between the two systems. So this disrupts the normal blood and oxygen circulation. This is actually most common in the brain or the spine. So we don't see a lot of these in the extremities as an orthopedist. For the most part, when we see these, they get referred to a specialist clinic. Usually there's a vascular malformations clinic at many of the major centers. These enlarge over time, and the larger they get, if they get really big, you can end up getting this shunting and this high output cardiac failure, which is tested frequently and not seen probably in clinical practice quite as often as in the test. Diagnosis is via MRI angiogram, and the treatments, again, just like hemangiomas, non-operative compression stockings, elevation. For larger ones that can't be controlled symptomatically with that embolization, and then in really difficult, extensive cases, open surgery. And again, most of us as orthopedists or pediatric orthopedists are not doing these. I do refer those out to the vascular malformations clinic. Digital fibromas, so these funky looking nodules that show up on fingers and toes, almost always in infants. That's the most common age group to get it. And it looks kind of like, you know, some sort of exostosis, like a weird osteochondroma. So you do need to get an x-ray, because if there's bone underneath it, you start going in a different direction than osteochondroma. And typically we just watch these because they will spontaneously resorb in 2 to 3 years. But if it's causing with shoe wearing, it's rubbing, it's causing ulcerations, then that's a good reason to go ahead and take it out. And the pathology, it's benign spindle cells, vesicular nuclei, and fibrotic stroma. And these arrows from Durham Net, New Zealand, show apparently characteristic inclusion bodies, which are supposed to clinch the diagnosis and differentiate this from other types of fibromatosis that we see in the hand. Desmoid tumors, again, mostly adults, but they do show up occasionally in teenagers, and it's a fibrogenic tumor that's very locally invasive. Typically occurs mostly on the shoulder, then the chest, and then the thigh. You can have multiple lesions in the same extremity, can occur in the sites of prior surgery or scars. And so one thing that's testable is that families who have familial adenomatous polyposis is at increased risk. And on exam, you have a very hard fixed mask. You can actually get nerve compression symptoms and limitations of moving your joint. Diagnosis is done via MRI, and on histology, you see fibroblasts, spindle cells, and lots of collagen. And the other thing that's testable about this is that it is 100% positive for estrogen receptor beta receptors. So the ones that are non-operative are really basically the ones that are inoperable. They're really extensive, they're in a really bad place that you really can't take out. Low dose chemo, tamoxifen, and again, that tamoxifen, it's that estrogen receptor blocker. So if it asks you a question like, say, one of these tumors is responsive to estrogen receptor blockers, it's desmoid tumors. And so the goal for when you treat operatively is that they'll stay where they actually regress with time. Operative, any symptomatic lesions, recurrent lesion, and it's wide resection with radiotherapy. And by doing that radiation, it does actually lower that recurrence. Last slide, peripheral sheath tumors, MRI for diagnosis and evaluation. So schwannomas are benign, well-encapsulated Schwann cell tumors. And so the main thing to remember is that because it's a schwannoma, that main nerve is going to be eccentric to the schwannoma and well circumscribed. So you can actually shell that schwannoma out. And so the excision is actually fairly easy. And neurofibromas, they can occur spontaneously. It's not always associated with a diagnosis of neurofibromatosis, but if it is, it's at a higher risk for malignant transformation. So that's something to think about. And the difference is surgically, they're really difficult to take out because they're kind of infiltrative with that tumor. They can actually obliterate part of that nerve. And so a lot of times you have to be ready to tell the family that you may not be able to just excise that from the nerve, that you're going to have to resect it and then do a nerve graft. And that's it.
Awesome. Thanks, Christine. So we're going to move on now to some systemic conditions. You kind of heard them mentioned briefly throughout the previous talks, but Carrie Hunselman from Boston will talk to us about systemic conditions that can affect actually both the bone as well as the soft tissues.
All right, great, thanks. I'm going to get my screen here. All right, can you guys hear me and see my screen?
Yes.
Great. So as you mentioned, some of these have been kind of noted before, these tumors. But what I want to go over is multiple hereditary exostoses, Langerhans cell histiocytosis, Olliers and Maffucci syndrome, and then neurofibromatosis are some of the more common systemic things that we'll see as orthopedic surgeons. So MHE is basically polyostotic osteochondromas. It is an autosomal dominant disorder. As far as testing, you're going to see the EXT1 and EXT2 gene mutations. Those do make up a majority of these cases, although there are other genetic mutations that don't tend to be tested. They are starting to test that it affects the heparan sulfate synthesis, which then affects downstream pathways. It's about 1 in 50,000. Males actually have a slight predominance because of income penetrance in females. Some study somewhere showed there's an average of 6 exostoses, but this is a really wide range for these. But technically speaking, there's at least 2 to have MHE. There is a 5 to 10% risk of malignant transformation into a chondrosarcoma from these, as opposed to usually like a less than 1% transformation. The other risk with this is skeletal deformity. So this is kind of a laundry list of things that we can see, but you can imagine it just depends on the location. But quite commonly are coxa-valga, of course, length discrepancies. You can have ulnar shortening with radial bowing. And so for that reason, these kids are often followed by orthopedic oncology and the limb deformity specialists in your department. So this is an example of a kid who has, multiple osteochondromas, but as you can see, fairly benign in regards to the effects on deformity and alignment, as opposed to this kid who has kind of the typical ulnar shortening, radial bowing. He has significant involvement of the proximal femurs, as well as this is actually a large one off his ilium. So quite a bit more involved. These are his bilateral humeri as well. When do we excise? This was kind of mentioned before. It's really the same thing as for solitary ones. If you're starting to worry about growth deformity, or if they're symptomatic, maybe pressing up against a nerve, and then you just have a little bit slight, if you're concerned about malignancy, obviously a higher lower threshold for MHE kids. This is just a reminder that removing these is not always a benign procedure. This is an osteochondroma of the proximal fibula that I removed, that actually when I got in there, it split the perineal nerve, the superficial and deep branch here around it. So just a reminder, these are not always super straightforward cases, and you want to be careful when you get in there. This is an example of one around the sciatic nerve with similar kind of consequences there. And this is one that actually caused a pseudoaneurysm in a proximal humerus. So you just want to be aware of these systemic conditions that can happen with fairly benign problems orthopedically. All right, Olliers and Maffucci syndrome. So these are multiple enchondromatoses syndromes. The difference is Maffucci's also has soft tissue hemangiomas associated. And your overall malignant risk is greater with Maffucci's. You can also have more visceral associated malignancies with Maffucci. Typically, there is unilateral limb involvement. For the non-orthopedic oncologist, the thing to know is if you're seeing maybe multiple enchondromas in a hand, it's good to just image the rest of that limb to check for multiple ones. There is an increased risk of chondrosarcoma transformation, anywhere from 15 to 30%. It can be higher. Some studies quote as high as 50% in Maffucci syndrome. For some comparison, chondrosarcoma transformation from a standard enchondroma is less than 1%. This is a non-hereditary condition. For your test, IDH1 and IDH2 mutations have been associated with both of these. And then for Olliers, there can be mutations in the parathyroid hormone receptor as well. These are often associated with enchondromas found in the epiphysis, although those can also be solitary, you're going to see a lucent lesion with well-defined borders and then your kind of chondroid matrix. But they can be a little bit more, you could tell maybe a little periosteal reaction there, a little bit more aggressive, and that would be one you're concerned with maybe malignant transformation. Langerhans cell histiocytosis. So this is a disease spectrum, really. Has had many names over the years. There's still a lot of research to determine, is this really truly neoplastic or more inflammatory, maybe a little of both. Basically, it's a clonal proliferation of histiocytes. You can have solitary bony lesions or multiple and with disseminated disease. It's actually a very rare condition, but it can often present as a primary bone tumor. It's more common in the Caucasian population, generally young people with a slight male predominance. It can often affect flat bones. Here's an example in the pelvis here of a lesion. These can be lytic lesions. They can be lesions that have a quite permeative appearance. These you have heard are the great imitator. So you can pretty much put LCH on any differential for the most part with any lesions. It depends on when you catch it in its kind of lifetime. So over time, they tend to become more defined and sclerotic, a lot of the bony lesions. This is one of the diseases that can be associated with vertebroma. They can have kind of low T1 signal that can be tough to pick up on, but quite bright T2 signal. And they do uptake contrast. Occasionally there's soft tissue masses, and for testing purposes, the electron microscopy shows the Burbeck granules. So this is one of those that it's just important because they may present to you with a bone lesion, but really you want to pay attention to systemic issues they may already have that could kind of point to this being more than just a bony problem. So 15% of patients that have multifocal disease have diabetes insipidus, exophthalmos from orbital involvement, in addition to the multiple osseous lesions. The problem is these kids can have multi-system disease, and their prognosis is usually based on what organs are involved. The bone marrow, spleen, and liver tend to be considered the high-risk organ systems. So these kids will generally get whole body imaging, usually PET scan. Depending on their involvement, they can get systemic treatment with chemo, or there are some new targeted therapies coming out. As far as a bone lesion, particularly some solitary ones, can actually be injected with steroid, and part of the kind of inflammatory process that we think is involved with that. Or you can do like a curettage for them. This is a kid with a pathologic clavicle fracture that was followed by an outside orthopedist and developed a lucent lesion during that time and presented to me with this. We got a biopsy and it was LCH. So you can see she got a PET that's really bright, and then she had skeletal involvement in her skull as well. So she's getting systemic therapy. Finally, neurofibromatosis. I'm going to focus on NF1 just because it's the most common form, and it's generally what would present to orthopedics. Again, for testing, it's that chromosome 17 mutation, that's the NF1 gene. NF1 has neurofibromas, gliomas, cafe au lait spots, as well as bony abnormalities. For your review, kind of when you go back to this is a little chart kind of distinguishing NF1 and NF2, and then just having multiple schwannomas. Again, this is kind of for a laundry list for later. This is the actual diagnostic criteria for NF1. So again, it's the cafe au lait spots. You're going to have neurofibromas. You check for the axillary or inguinal freckling, and then other bony lesions, and then relatives with it are among some of the features of it. And this was actually just touched on, so I will kind of skip past this just to distinguish schwannomas and neurofibromas. The only thing I will say is generally the schwannomas are going to be associated with NF2, and the neurofibromas can be associated with NF1. But it is important to remember that both of these still, for the majority of them, present as solitary tumors. They do have a higher rate of malignant transformation, however, the neurofibromas into malignant peripheral nerve sheath tumors. And really they have an 8 to 13%, kind of a range of a lifetime incidence of these. And so this is an example of one here. Can still look fairly benign, but you really want to follow these over time to check for any changes or growth. So again, kind of a common theme, you're going to excise for either growing or symptomatic masses. Really, the important part is to follow for a clinical exam, particularly patients with multiple neurofibromas. You're not going to image all of them necessarily, but you do want to image growing ones. And often these patients, depending on their involvement, will get full body MRIs to follow them. Neuro-oncologists follow along as well, and there is some systemic therapy used occasionally for unresectable disease. This is an example of a plexiform neurofibroma that would fall under that category. So for these systemic conditions, really it's important for orthopedic oncologists and general orthopedists, pediatric orthopedists, to know these solitary lesions that can occasionally be associated with systemic condition, particularly in the pediatric population. I always use a term that I stole from one of my attendings, but history and physical first, that can really cue you into maybe some sort of systemic involvement. But orthopedics is often the starting point for these, some random bone lesions. So you can make a big difference in these kids' lives if you can help diagnose something that's affecting them more than was realized. And you're going to work in conjunction with your other orthopedic colleagues, depending on what you do, whether it's limb deformity or oncology or upper extremity. And then a lot of times other specialties, of course. This is kind of a team sport for these patients with the systemic conditions. But that's really it. Thank you.
Awesome. Thank you so much, Carrie. So we're going to move on now to the bad actors, so to speak. Well, some of those were somewhat bad to some extent. But we're going to talk now about malignant bone lesions from Alex Arcada at CHOP.
Great. Thanks, Josh. Can you, here, let's see. Do you guys see it?
Not yet.
With trying to test share my screen.
Okay.
There you
What
go.
about now? Okay.
Yep, you're good.
All right. Let me know. My internet's a little unstable, so if I disappear for more than 4 or 5 seconds, let me know. Thanks for the invite. Amazing talk so far. I've learned this is great. So I'll try to finish it up with some malignancies. So like was said, hopefully you never need to treat a malignancy if you're not going into this business, but you need to be able to recognize. And for the residents and fellows that are paying attention to this webinar, there are certain things that you know for test taking as well. So the first thing is knowing what are the actors. So osteosarcoma and Ewing sarcoma are going to be the most common primary bone tumors we're going to see in kids. And when we talk about osteosarcoma, it can be divided into intramedullary osteosarcoma or surface osteosarcoma. And surface osteosarcoma can either be high or low grade, and then it has that classic difference between parosteal and periosteal. But that's really at a pathology level, where we can say it's a surface osteosarcoma. It can be either high or low grade. The intramedullary one, the one that it's high grade, it's what we refer to as conventional osteosarcoma. And then the subtype can be of many different ones. We don't know what causes osteosarcoma. We know that there's some people that have a genetic predisposition for it, and especially people with the hereditary form of retinoblastoma, and that's associated with the RB1 gene. People that have familial history of several tumors with leaf-forming, and that's associated with the p53 gene. So those are the two main ones, and then you have many others that will lead to the development of osteosarcoma. Ewing's. This is the only pathologist that has ever made to the cover of Time magazine. So it's the cancer man Ewing. And, you know, the interesting thing is that Ewing never really described his tumor the way we know his tumor. He described what was called an endothelial myeloma, or a vascular tumor. We know that Ewing sarcoma, it's a PNAT tumor, but we still refer to as Ewing sarcoma. The classic translocation that we all learn in medical school, the 1122, can be identified in the majority of the cases, but not as high as you'd think. More recently, the development of a better technology and the identification of EWS1 or FLY1 gene, it's a much better way to make this diagnosis and differentiate Ewing's from other small round blue cell tumors that you can come across, such as rhabdos, lymphomas, etc. Now, I put the clinical features together because those tumors in reality are very similar. Most of the primary bone tumors are more common around the knee and the shoulder. Those are the most active areas of your body, so it's metaphyseal region of the long bones. Obviously, they can involve the pelvis, they can involve the spine. Ewing's a little bit more so than osteo. About 10% of the Ewing's will involve the exoskeleton. Metastasis will be present at diagnosis in about 20 to 30% of the cases, especially lung mets, and then for Ewing's, bone marrow mets. So that brings to the prognosis, which they also share a lot of similarities. So site is important due to our ability to treat the tumor or to get rid of the tumor, achieve wide margins with resection. That's why site is so important. The presence of metastases or skipped lesions, that's a bad prognostic sign. That's why we always get an MRI of the entire bone to make sure there's no skipped lesions. We do CT of the chest for everyone because lung is the most common place for the metastasis. For Ewing's, we'll do bone marrow aspiration routinely. And obviously you need to check the rest of the body, and that historically has been done with bone scan. Some places evolved to do PET CTs. Now at CHOP, we've been doing PET MRIs for all those patients. Labs are not that helpful except for those two. ALK-PHOS in cases of sarcoma, depending on how elevated it is, can be very prognostic, and LDH has a similar effect in patients with Ewing's. Response to chemo and histological type, so those things are associated, extremely important in terms of prognosis. We've heard a lot about radiographic appearance. Marty gave a great talk on it. The osteosarcoma is pretty classic. Nothing else looks like this kind of a destructive lesion with sunburst appearance, triangle, etc. Ewing's has more of a layering of the new periosteum, and both have soft tissue masses classically. Before chemo was a thing, you had an osteosarcoma, you receive radiation that we know doesn't work for osteosarcoma, and if your chest was clear, then you got an amputation. Standard of care, 20% survival after 5 years. So that was the standard of care pre-chemo. With chemo, now we're able to save over 80% of the patients. So extremely significant improvement. We still have 20% of the patients that we can't cure. So there's a lot to be done. So the standard of care has become neoadjuvant chemo. Then you do your local control, usually with surgery, and then adjuvant chemo. And when people start giving chemo, I noticed that amputation limb salvage had really the same overall survival. There was this big push towards limb salvage, which is what we do in about 90% of the cases. That being said, amputation is still needed at some situations, And it has not really evolved from the 1500s except for antibiotics and anesthesia. Between amputation and limb salvage, we have to talk rotationplasty, which is one of my favorite surgeries from a functional standpoint. Therefore, I like to refer to it as functional amputation. So this is an 8-year-old, had a pathologic fracture, was treated elsewhere. They put an X-fix. This is the second version of the X-fix. The first one had the distal half pin through the joint, which led to the need of an IND of that joint. So you can see the incision for the IND of the joint and completely contaminated compartment. Except the back wasn't. So we're able to remove widely and perform the rotationplasty instead of hip disarticulation. And she actually did well functionally. So the rule number one of limb salvage is be able to remove the tumor, then start thinking about the rest. And in kids, I like to divide limb salvage in 3 groups: physiosparing, sparing, joint sparing, or just limb sparing. And there are many options. So biological reconstruction is always preferred in kids when possible. That's the use of allo or autograft, or sometimes bone transport. The allograft results are great long-term in terms of being able to keep the limb, but you should expect high need for a second surgery. To mitigate that, the application of a vascularized fibula with an allograft has become really one of the standards of care in tumor reconstruction. So that's the Campana procedure. Let me show a couple examples. This is a 14-year-old who had an osteosarcoma. You can see the resection. The allograft was cut to match the bone that was resected. We prepared the bone in the back table and slid in a vascularized fibula. You can see the pedicle of the vascularized fibula and the internal fixation. This is a 9-year-old with Ewing sarcoma, similar situation. You can see this is the proximal part, the distal part of the resection, the intercalary resection. In this case, because she was little, we just used half of a segment of bone instead of the whole bone. So it's a modified Campana, and you can see the pedicle and the reconstruction being able to save the physis proximally and distally. Endoprosthesis is versatile. It's the classic limb salvage. You're able to reconstruct whatever you remove. You have great motion. You have good stability. It looks normal, but you know it's not normal. Let me show you an example of how endoprosthesis, though it's very useful. This is a 9-year-old that was going to have a Van Ness until the MRI preoperatively showed a skip mat. And we ran out of that option, and he received total femur replacement. So you can add the pieces as much as you can, or as much as you want, I should say. Now, we have to take into consideration the activity level and expectations from that's extremely important, as well as the amount of growth remaining. And we've been trying to extend the prosthesis for as long as we've been putting prosthesis on. And for the longest time, you needed to have a little surgery, but it was an extra surgery with risk of infection, and length was limited, and the cost involved in it. So then now we have non-invasive extendable prosthesis. This is an example of the Stanmore procedure. Stanmore prosthesis, very similar to the magic rod for the spine and precise nail for limb lengthening. And the patients can be lengthened in clinic without any pain, and you get about a 4 millimeter lengthen segment per time that you do your lengthening procedure. This is a 12-year-old that had a Stanmore. Those are all custom made. You can see this takes some preparation to get this prosthesis made, and intraoperative pictures and results. He's due for lengthening actually in a couple months now. And just to have to finish by everyone, the kids want to be active. They will be active whether you tell them to be active or not, and we have to take that into consideration. because those prostheses have a limit of what they can take. So in summary, this is not to be seen as a limb salvage surgery, as life salvage surgery, and not one size fits all approach will work here. So some kids are still going to be better off with an amputation of a Van Ness rather than some of the fancy prostheses I showed you. Thank you very much.
Outstanding. Thank you very much, Alex, and thank you to all of our presenters this evening. I hope everyone has a great night and enjoys the summer. And if things are still bad, we will be back in the fall. Take care, everyone, and thanks again.
Thanks, Josh.
Thank you. Have a
Thanks,
great night.
Josh. Appreciate it.
Thank you.
I'll talk to you all soon, I hope.
I hope so. I sent you an email. Don't forget to read it. Respond later this week.
Okay, sounds good.
All right. Bye.
Bye-bye.